This is just the first publication on ASD occlusion, published in 1974 by King and Mills. And recently, in 2003, 4 patients were still alive. Of the 5 treated patients, all of them had complete ASD occlusion. It was a 23 French that was necessary to implant this device. Balloon sizing was developed. It was a huge sheath necessary to implant this device, and balloon sizing was developed because no echocardiography was available at that time. Although successful, only 5 patients were treated with this original device. So the indication for treatment, we all know symptomatic patients or hemodynamically significant shunt QP to QS more of 1.5 to 1, right ventricular enlargement, or if there is paradoxal septal movement, patients with a small ASD, PFO, and a history of paradoxal embolism resulting in either stroke, TIA, or peripheral embolism. So there are several forms of ASDs. You know that we can close a foramen ovale, we can close holes that are in the fossa ovalis, we cannot close septum primum defects. There is now newer reports that you may be able to treat patients with sinus venosus defect with the combination of covered stents, but we have not done that yet. And sometimes it's possible to close a coronary sinus defect, but in most times not. So mostly we're talking about these defects in the septum. And here you see an anatomic picture of a typical ASD, which is kind of round shaped. Now, it was Jürgen Hörer who looked at our surgical results between 1974 and 2000 adults. He looked at a total of 281 adults. Mortality was 0.7%. And what was interesting, that 88% of the patients had some kind of complication. So even though it is standard, and some people may call it gold standard, the complication rate is higher than what we see after interventional closure. So I'm talking about the Ceraflex ASD occluder. You see him here, how it comes packed. It's a transcatheter preloaded device with a flexible attachment. I really like this attachment. There's no hub on the left side, and there's a special coating which should prevent the release of nickel. It's a relatively comfortable system. You screw it together, you flush it, and you can use it. So here comes the sizes in the waist between 6 and 32 millimeters. The disc sizes are larger, of course, as it's always, and here's the French sizes of the sheaths that are necessary. The sheath sizes are a little bigger than what we know of the Amplatzer. The criteria for an ASD closure for an ideal patient is if it's centrally located, if the native size is between 15 and 15 millimeters plus 14 millimeters septum length, and if there's enough rim. In our clinic, since Peter joined us some 8 years ago, we try to close the ASD just with echo. Now, this is our experience in Munich. You see here, we started in 1996 with the angel wings. And if you look at the year 2018, we used a lot of Ceraflex. At that time, we were doing the study. We used Occlutech. We used few Amplatzers and some Gore septal occluders at that time. So this is our total experience. You see, we've been treating 1,790 patients, of whom 1,144 were ASDs and 646 were PFOs. Lately, with the 3 studies coming up, we are quite running up with PFO closure. And you see, we used 206 Ceraflex, PFO, and ASD occluders lately. So I'm coming to the Ceraflex experience we have in Munich. The smallest patient was 8 months. The defect was 5 to 6 millimeters. 6 kilo patients, and the largest defect patient was 62 years old, 86 kilos, and balloon sizing was 29 millimeters. So here is a typical, this is the largest patient you saw. There's deficient aortic rim. You see the typical color flow mode, and there was no aortic rim for more than 45 degrees. You see here the whole native, it was 18, but we came to 29 millimeters with a balloon test. So now you see how we do it. We, under TE guidance, we place the long sheath into the pulmonary vein, then we place the occluder, we test for stability. And what is also very nice about the Ceraflex, if you let go of it, it doesn't change the position. Here in this picture, you see the big occluder, 32 millimeter occluder positioned, and the cable is removed and it doesn't change position. We really like that. What we also like, because it's flexible, it doesn't tilt through the aorta, and this flexible device helps us to position the occluder if there's deficient aortic rim. So we really like the occluder for that also. We participated in 2 studies. One was the LifeTech Ceraflex post-market surveillance study. I think, Kevin, you also participated in that one. Dublin is also one red dot.
Yes, I did, yes.
So that was Dublin, Paris, Zurich, Milano, Munich, Leipzig, and Berlin. So I'm talking about that first. Here you see it was a total of 120 patients that were enrolled. You see the centers that enrolled patients, 6 sites, 55 ASDs, 47 PFOs, and 18 docs were closed in 6 sites. And the German study, we were more or less setting it up between Leipzig, Munich, and Freiburg. And since there's no data yet available for me for the international study, I will talk more about this because I have more data on that. So inclusion criteria is as always, exclusion criteria also is as always. I will not talk so much about that. We did a screening, then we did the intervention, then we did the echo at discharge, and we did a 6-month follow-up examination, which was just a regular clinical examination with echo. You see that 143 patients were screened and 43 were not treated for several reasons. So a total of 100 patients were scheduled for the intervention. Median age was 24 years, more or less, from 3 to 80. Median weight was 44 kilos from 13 to 120. And gender was more females than males. And defect size was between 4 and 30 millimeters in diameter. Here you see we had 36% superior position, 11% anterior position, 46, most of them central, some posterior ones, and some inferior ones. How was device selection done? With a balloon stop floor in 74%, with a waist in 15%, native measurements in 8%, and angiographic measurement was done in 2 cases. So procedural time you see here was median 41 minutes, 15 to 228. Exclusively TOE-based closure was done in nearly 70% of the patients. If radiation was used, the time was short, 0.9 minutes, and 96% a single device was used. 3 patients needed a second device. There was nearly no residual shunt in the patient, just a small one. And 98%, there was no change of the device position after release. Here you see the occluder sizes that we use. You see mostly the 12 millimeter and 8 and 18 millimeter were used most frequently. So we're coming to complications. Minor vascular complication was 6. Air embolism that was seen in ST elevation was 2. And we had 2 device embolizations. You see how one device is taken out here. Now, if device embolization occurs, and here you see it's not a Ceraflex, it's an Occlutech, that happened to me, it may be a problem to get it out. You see that this device is in the aorta, and to get out an occlutech is quite challenging. In this case, we were able to put in a long sheath and bend the long sheath with a stiff wire, and we could connect it with the biotome, and so we were able to take out this embolized device really nicely. But some other day, it happened to us that we had an occlutech device that was 28 millimeters, and we could not retrieve it, even though it was possible to snare it. And so we had to send the patient for surgery. So on the bench, we tried how to get out this occluder. Here you see an occlutech 10 millimeter, it's no problem. But if you take a device that is larger than 26, you can't get it out, not even through an 18 French sheath. And so we scheduled animals, an animal test, and we were very happy that we have the Maslanka snare there for the big devices. Here you see our animal test, and this is a Ceraflex that is embolized in the pig. It was a pig, and we could easily get it out here with a snare, but this was a 16 millimeter device, so it was possible to get the 16 out. So 10 and 16 we could get out easily with a snare. But if you take big devices, and you see here a very big device, 40 millimeter occlutech device, we used a snare to fix it, and then we used the Maslanka really to get it out, because this will never go out if you don't have the Maslanka or a really strong grip. So follow-up data from our patients are available now in 69 patients. You see here, so we don't have the full follow-up yet, but the long-term results are really nice. So I may conclude that ASD closure with a Ceraflex device is possible, safe and effective. The device adapts well to all atrial structures during deployment. It's easy to handle, success rate is really nice, nearly no angle change after release. And so far, I said there's no device embolization, but there was two that embolized. There was no thrombus formation during follow-up. And if you want to remove big umbrellas, the Maslanka biotome is very helpful. And Stanimir published this in the Cardiology in the Young in 2018. So thank you very much.